All right, welcome everyone. We're going to be doing opportunistic infections today. I'm Chicago DLS Inc. I do one-on-one and group sessions for the Naplex and the MPJE. If you have taken the Naplex before and have a score report you'd like to discuss, send me a DM. If you've taken an assessment for your first time and would like some feedback, also send me a DM. Shout out to Suspicious Bunch and Pharma Turtles for arranging this. The resources I use are RxPrep and Pass Naplex Now. Save any questions. I'd be happy to answer all of them at the end of the presentation. Now, these are mini reviews. Definitely go more in depth on your own. And if you decide to do a session, we can do that as well. So let's start with a little bit of background. Immunocompromised patients are the ones that suffer from opportunistic infections. This can be due to primary immunocompromised conditions or secondary causes. So, primary causes would be congenital causes, and secondary are going to be due to HIV, also systemic steroids, or other causes such as immunosuppressants. So OIs is the abbreviation I'm going to use for opportunistic infections. They can be bacteria, viruses, protozoa, and fungi. HIV is a major cause where the CD4 T lymphocyte count is less than 200 cells per millimeter cubed. Systemic steroids can also cause a patient to become immunocompromised. Prednisone greater than or equal to 14 days at a dose of 20 milligrams or more, or 2 mg per kg per day. Asplenia can be due to sickle cell disease or splenectomy. Asplenia is the absent absence of a spleen. And on the right side, you'll see a slide. The arrows are pointing towards sickle cells, cells that are sickled. Also, in post-transplant patients or other autoimmune conditions where the patient is taking immunosuppressants, and then chemotherapy, especially those that can cause neutropenia. Neutropenia is going to be the ANC is less than 500 cells. Can anyone type in the chat what ANC stands for? Once again in the chat, what does ANC stand for? All right. So, if you typed in absolute neutrophil count, you are absolutely correct. Great job. The next slide, we're going to talk about primary prophylaxis in HIV. And first, we're going to talk about PJP, which is pneumocystis jirovecii pneumonia. It was formerly known as PCP, and that occurs when the CD4 cell count is below 200. Preferred is going to be Bactrim daily, either double strength or single strength, until the CD4 cell count is above 200 with antiretroviral therapy. Or if the CD4 cell count is 100 to 200 and there's an undetectable viral load for greater than 3 months. So, similar guidelines for Toxoplasma gondii. This can cause encephalitis or encephalitis when the CD4 count is below 100. There's a graphic in both RxPrep and Naplex Now where they have a list below 200, below 100, below 50. That is important and very high yield to memorize. Um, all of these treatments are in addition to restarting or getting the patient on the right regimen for ART. And alternatives for Bactrim are going to be dapsone or atovaquone, as well as pyrimethamine and leucovorin. We'll talk more about that later. MAC is Mycobacterium avium complex. Patients are affected by MAC when their CD4 cell count is below 50, you always have to rule out disseminated disease. Azithromycin 1200 milligrams is preferred weekly. Alternatives are going to be azithromycin 600 mg twice a week or clarithromycin 500 mg BID. We can stop once the ART regimen is fully suppressing the HIV infection. Can anyone tell me a brand name for clarithromycin in the chat, please? Clarithromycin brand name. On the right side, you'll see scan with toxoplasmosis on the right side. All right. Treatment of other opportunistic infections. Give everyone a minute to type their answer in. Brand name for clarithromycin. On the right side, you'll see candidiasis. And after completing initial treatment, sometimes we need secondary prophylaxis to prevent recurrence. HIV patients with thrush, we prefer systemic treatment. Thrush is also known as candidiasis. This is going to be a white film in the mouth and throat. Fluconazole is preferred. Alternatives are going to be itra or itraconazole and posaconazole. And if it's esophageal candidiasis, voriconazole or echinocandin. If you answered Biaxin for the brand name, that is correct. Great job. Clarithromycin is Biaxin. It's also available in Biaxin XL. Brands and generics are very important. In the resource section, there is a link to the top 200 and top 300. I always counsel my students, top 300 is what you're looking for. The Naplex can have, and the CPJE can have brands only, generics only, or a mix. So it's good to be prepared. Now, you don't have to memorize all 300 in one go. Break them up. Do 10 a day, 20 a day, 30 a day, whatever works for you. Now, cryptococcal meningitis treatment that we prefer is amphotericin B plus flucytosine. Alternatives are going to be fluconazole and flucytosine or ampho B plus fluconazole. Secondary prophylaxis, low dose fluconazole. Cytomegalovirus, preferred is going to be valganciclovir or ganciclovir. We'll get into these agents later. Alternative can be foscarnet or cidofovir. There's no secondary prophylaxis. We try to maintain the CD4 cell count above 100. Aspergillosis, nasty deep fungal infection, voriconazole or ampho B, and then coccidioidomycosis. You can do fluconazole, itraconazole, or ampho B. All right, let's talk a little bit about PJP. The old name we talked about is PCP. On the right side, you'll see a chest x-ray with quite a few patchy infiltrates. Prophylaxis is going to be Bactrim, one double-strength tablet daily, and we start when CD4 is below 200. You can also, for treatment, we're going to do Bactrim and prednisone. Prednisone is going to be for 21 days. And there are different dosing from mild to moderate and then moderate to severe infections. Mild to moderate, we can do orally, 2 double-strength tablets every 8 hours. And for moderate to severe, we can do IV, and we do the trimethoprim component of 15 to 20 mgs per kgs per day in 3 or 4 divided doses. Some adverse effects or side effects are going to be rash fever, neutropenia, and hyperkalemia. If there's a sulfa allergy, this is very important. We recommend dapsone. You can do 100 mg QD or 50 mg BID. Now, dapsone is a sulfone, but it's usually well tolerated. We will avoid if the patient has a serious reaction to sulfa, such as Steven Johnson's or TENS. Atovaquone is another alternative. We do 1500 milligram daily suspension with food. Next, we have toxoplasmosis or T. gondii. On the right side, the graphic that has the blue cells, that's actually toxoplasmosis. And on the bottom right, we have a CT demonstrating the edema around toxoplasmosis lesions. It can cause encephalitis or encephalitis. It can also affect other organs, including eyes and lungs. We start prophylaxis when the CD4 is below 100. And for prevention, we can do Bactrim daily double strength, one daily. If there's a sulfa allergy, we can do dapsone plus pyrimethamine and leucovorin, or we can do atovaquone with or without pyrimethamine and leucovorin. A third option is going to be clindamycin 600 milligrams QID. Does anyone know a brand name for clindamycin? Once again in the chat, clindamycin, if I can have a brand name. All right, while you type that in, let's talk about treatment options for T. gondii or T. gondii. There's a combination of three agents, sulfadiazine, pyrimethamine, and leucovorin. So pyrimethamine is, the brand name is Daraprim, and it inhibits the parasitic dihydrofolate reductase. It does penetrate the brain, and then leucovorin reduces the toxicity associated with pyrimethamine by protecting against vitamin B complex deficiency. You may need to use adjuvant corticosteroids, but use carefully because these patients are already immunocompromised. If you answered Cleocin in the chat, you are correct. I also would have accepted Cleocin HCl or Cleocin phosphate. Great job. If you don't know any of the answers to the questions, make sure you take notes and go back and review today after the session or tomorrow. That will greatly help with retention. Mycobacterium. Bottom right, you'll see a slide with the actual mycobacteria. And in general, Mycobacterium is found everywhere. Different species can be found in water, soil, foods, and animals, so it's difficult to avoid. However, if you're immunocompetent, you don't have any problems. You may have come, if you went outside today and sat in the grass, or planning to do that tonight, you may come into contact with Mycobacterium. So the symptoms are similar to TB. You'll have fever, cough, night sweats, chills, weight loss, fatigue, and hemoptysis. Now, how would you differentiate between MAC and, say, TB? One, when you do blood work, and we will see the CD4 cell count. Another could be culture. Third, there's a test called quantiferon gold, which is the gold standard for tuberculosis. Primary prophylaxis for MAC is not recommended for adults and adolescents who immediately initiate ART. If their antiretroviral therapy is not fully suppressive and the CD4 count is below 50, we rule out disseminated MAC. We can start prophylaxis with a macrolide. Clarithromycin, aka Biaxin, 500 mg POBID, or azithromycin, 1200 milligrams orally weekly. M-Kinsazi is another one. Usually involves the lungs, but can include the liver, spleen, and bone marrow. Symptoms are similar to MAC. Treat the same. So, if you have a patient who has upper respiratory symptoms along with systemic symptoms that make you suspect TB or Mycobacterium, whether it's MAC or Kansazi, you would probably treat the same. Very good. Now let's talk about CMV. Uh, we use it to treat. There's not a curative treatment. On the top right, you'll see CMV lesions on the skin. And on the bottom right, that is your eye. It's your optic disc. and that's what it looks like when there's CMV retinitis. So I've listed the medications here along with their brand names, routes, and main adverse effects. Ganciclovir is going to be cytovine, IV, can cause renal dysfunction as well as seizures. Valsite is valganciclovir, it's PO and renal side effects. Cidofovir is Vistide, available IV. Kidneys once again are affected as well as neutropenia. And then Foscarnet or Foscovir, available IV, nephrotoxic, and seizures. So let's talk a little bit about each of the drugs. Bottom right, we have a graphic for Valsite. Valganciclovir is the prodrug for ganciclovir. Dosage form is PO. They're 400 mg tablets. So the dose will be 900 mgs orally BID for 21 days, followed by just 900 mgs once daily, take with food. We'll watch for myelosuppression, monitor CBC, and reduce dosage in renal dysfunction. Ganciclovir, we use it for CMV retinitis and then prophylaxis as well in transplant patients. It's also available, for IV dosing, we'll do Zergan for herpetic keratitis. This is caused by the herpes simplex virus in the cornea. Administer slow infusion over at least 1 hour. Reduce dose if the creatinine clearance is below 70. Always, always, always hydrate the patient. Bottom right, we have Foscovir or Foscarnet. It's available IV for CMV retinitis. Renal impairment is a side effect. The patient requires adequate hydration. Another side effect are seizures, and this can be related to alterations in plasma electrolytes. Sometimes you may require additional supplementation. Next, we have Cidofovir, which is Vistide, and it's only indicated for the treatment of CMV retinitis. We prescribe it IV with probenecid once weekly for 2 weeks, and then once every 2 weeks for maintenance therapy. Renal impairment is a big adverse effect. We do IV prehydration with normal saline and, of course, probenecid. Neutropenia is an issue, and we monitor intraocular pressure. All right, other malignancies that are associated with AIDS. Remember, HIV is the virus, and AIDS is acquired immunodeficiency syndrome. That's what happens when the HIV is not controlled. You can have cervical dysplasia or cancer. We can find that on pap smears, anal dysplasia or cancer, and certain lymphomas. On the right side, you'll see on the top, that's Kaposi sarcoma of the skin. And on the bottom right, you'll see their facial lesions. They can range in color from pinkish red to brownish blue and caused by human herpes virus 8. They're not usually life-threatening. However, when they occur on the face or in prominent areas, they can cause emotional troubles. Any lesions that are in or on an organ, such as the lungs, liver, or digestive tract, they're more dangerous as they can bleed and cause bleeding. Treatment can be radiation or chemotherapy. Now, I have 4 or 5 practice questions. For those of you that are new, I'll read the question. When I'm done reading the question, you can put your answers in the chat. If you're unsure of your choice, go ahead and pick something and put a question mark by it, and then just make a note to go back and review. If you are guessing and you're not sure, feel free to not put a question mark. It's all up to you. Remember, there are no points off here if you get something wrong. And this is a place where you want to get something wrong because you want to get it right on the Naplex. Practice question 1. JH is a 60-year-old man who was seen in clinic for follow-up after initial testing confirmed positive for HIV infection. His HIV RNA is 1.5 million and CD4 T cell count is 90 cells. He has no documented OIs, no resistance mutations were identified. His HLA-B5701 is negative, no known drug allergies, and creatinine clearance of 80. Which of the following prophylaxis regimens would be required? Choice A, trimethoprim sulfamethoxazole. Choice B, rifampin. Choice C, azithromycin. Choice D, trimethoprim sulfamethoxazole plus azithromycin. Or choice E, no prophylaxis required. One chance to get an answer in. Okay. All right. So, anyone else want to choose something before we talk about it? All right. So the correct answer is A, Bactrim. The CD4 count is below 200, and so we'd want to do prophylaxis for PJP. Additionally, the CD4 count is below 100, so we want to do prophylaxis for toxoplasmosis. Bactrim covers both, and there are no known drug allergies. Rifampin is only used as a prophylaxis in close contacts of patients with Neisseria meningitidis when the meningitis is confirmed. Choice C would be for MAC, and MAC is not required. Choice E is incorrect because CD4 count is below 200. We have to do some kind of prophylaxis. Can anyone tell me what the HLA-B 5701, what drug that has to do with? And I will accept either the brand name or the generic if you are familiar. Once again, HLA-B 5701, what does that have to do with? Starting to get some answers. So, the correct answer is going to be abacavir, and the brand name that I have is Xiagen. Abacavir and Xiagen. Uh, Epzicom has abacavir and lamivudine, so I guess technically your answer is correct. And let's talk about why. Uh, the HLA-B 5701 can cause a hypersensitivity reaction to abacavir, and therefore it is contraindicated in patients, especially if they've had a prior hypersensitivity reaction. So, no go for abacavir with 5701. Great job. Anyone have any questions or concerns about practice question one or the presentation so far? All right, if you think of one later, type it in the chat or send me a DM. Next question. Which of the following would be most appropriate in a patient with HIV regarding PCP or PJP prophylaxis? Choice A, doxycycline, choice B, Bactrim, choice C, erythromycin, and choice D, augmentin. All right. The correct answer for this one is going to be Bactrim. Sulfamethoxazole and trimethoprim is the drug of choice for PCP or PJP prophylaxis. All right, great job, everyone. Practice question 3. Ambisome or amphotericin B liposomal formulation is an IV agent used in the treatment of various fungal infections. Which of the following statements regarding ambisome is true? Select all that apply. Choice A, ambisome 50 mg vials must be reconstituted with SWFI and then further diluted in dextrose. Choice B, ambisome must be filtered using a 5-micron filter when injecting the reconstituted drug into the final diluent bag. Choice C, when administering ambisome, the patient's IV line should be flushed with D5W after administering the drug. Choice D, incidence of nephrotoxicity and infusion-related events with ambisome are higher than with fungizone, which is the deoxycholate formulation. Choice E, there are no recommended dosage adjustments in renal or hepatic impairment for ambisome administration. Remember, this is a select all that apply. There may be one correct answer, all of them may be correct, or anything in between. Both RxPrep and Past Naplex now do a great job of not setting patterns when you're attempting these type of questions. Right. Anyone else have any answer choices for this one? It's okay if you don't know. Just make a note to go back and look it up. All right, very good. So this has several correct answer choices. We have A, we have B, we have C, and we have E. So looks like we have a good consensus. And let's talk about why. So choice A Ambisome has very specific instructions regarding the prep and admin, and this is an important drug for hospital pharmacists to be familiar with. It's only available in 50 mg vials and must be reconstituted with SWI. If you reconstitute it with bacteriostatic water, sodium chloride, or other fluids that contain benzyl alcohol or electrolytes, precipitation may occur. So, choice A is correct. It further diluting it in dextrose using a 5 micron filter, which is supplied with each vial. It prevents microparticulate induced phlebitis. Each filter should only be used for one vial of drug. An inline membrane filter may also be used during infusion, in addition to filtration during compounding, as another preventative measure against phlebitis. D5W is the most common diluent. There are studies that show stability in D10 and D20W and can be used in pediatric patients who require fluid restriction. B is true. The final product must be protected from light. So good on that. Choice C is also true as written. The IV line should always be flushed after administration of Ambisome. D is incorrect. I'm glad no one chose it. Ambisome has a lower rate of nephrotoxicity and infusion-related events when compared to fungizome or fungizole. Now, choice E. Ambisome can cause significant nephrotoxicity. However, it does not require any renal or hepatic dose adjustments. If a patient is on traditional hemodialysis, it should be given after dialysis on those days. So, if you chose A, B, C, and E, that was correct. If there are infusion-related reactions, you can pretreat with acetaminophen, diphenhydramine, hydrocortisone, or a combination. All right, any questions or concerns? Can anyone tell me the mechanism of action of amphotericin B? Put it into the chat. What is the mechanism of action of amphotericin B? How does it exert its antifungal effects? All right, well, I give everyone a chance to answer. Let's talk about practice question 4. For an HIV infected patient, at what CD4 threshold should Mycobacterium avium complex or MAC prophylaxis be initiated? Choice A less than 200, choice B less than 100, choice C less than 50, and choice D less than 25. All right, and while you're choosing your answer, it does disrupt the fungal cell wall because it binds to ergosterol, and that leads to pores and leakage. Pores being PORES. All right, whenever you're ready, type your answer into the chat for practice question 4. All right, very good. So the correct answer here is going to be C. Current guidelines recommend MAC prophylaxis to be initiated when CD4 falls below 50 or has a history of disseminated MAC. Great job. Great job. All right, last but not least, practice question 5. Practice question 5 says DP is a 60-year-old female with a history of hypertension, hyperlipidemia, and stroke who is receiving induction with cytarabine and daunorubicin for acute myeloid leukemia. She has allergies to penicillin, rash, and aspirin rash. Home meds include Plavix 75 mg PO daily, Lipitor 40 mg PO daily, and lisinopril 20 mg PO daily. Today, DP has new onset shortness of breath, cough, and a positive galactomannan test. Her calculated creatinine clearance this morning was 60 ml per minute. She is to be started on IV VFend for presumed invasive aspergillosis with further workup pending. Which of the following is or are true about VFend in this patient? Select all that apply. VFend, by the way, is voriconazole. So choice A, VFend will inhibit the metabolism of Plavix, potentially increasing the patient's bleeding risk. Choice B, VFend will induce the metabolism of Lipitor, potentially decreasing the effectiveness of Lipitor. Choice C, VFend may cause QTC prolongation. Choice D, VFend may cause visual disturbances. In choice E, based on renal function, the patient should be given 50% of the dose. And this is the last practice question. All right, anyone else? All right, very good. So for practice question 5, the correct answers are going to be C and D. And let's talk about why. So A is incorrect because voriconazole inhibits CYP2C19 and 3A4. Plavix is an inactive prodrug that must be activated by 2C19. So if voriconazole is inhibited or is inhibiting 2C19, less Plavix will be converted to its active form. So this will increase the risk of thrombotic events, thrombosis. So not bleeding, but thrombosis. Lipitor is metabolized by 3A4, so voriconazole would increase the serum concentrations, increasing the risk of toxicities. So choice B is also incorrect. It is backwards. Now, voriconazole can cause QTC prolongation as well as hepatotoxicities. Visual disturbances, including blurriness and color changes, are adverse effects specific to voriconazole. So V for VFen, V for visual disturbances. They do stop once you stop therapy. Now, voriconazole for choice E is almost entirely cleared by hepatic metabolism, so renal dose adjustment is not required. Now, if the patient is receiving IV, it contains an inactive ingredient called cyclodextrin that can increase drug solubility and can accumulate in patients that have renal impairment. So we have to be careful. With patients who have a creatinine clearance less than 50, they should only receive oral voriconazole, which does not contain cyclodextrin. Okay, so great job. Great job, everyone. So that brings us to the end of the mini lesson and the practice questions for today. Does anyone have any questions or concerns about anything we talked about, the Naplex or the MPJ in general?